Hospice is different things to different people. Depends on where you are in the hospice world. At its most basic, hospice is an insurance benefit. It seems very cold to say that, but that's what hospice is in the United States, is an insurance benefit that says that when you have a life-limiting illness and a prognosis of less than 6 months, you are entitled to the benefits of hospice. And hospice, in that sense, then becomes much more than an insurance benefit. Hospice then becomes a team of people who focus their efforts on giving you the best quality of life, the most comfort for as long as we possibly can. So that's when hospice becomes a very human thing, a very patient-centered thing. More concretely, hospice to patients who are extremely sick and clearly at the end of their lives or having severe symptoms is a building where they can go and get taken care of. So we have a center here in Mount Lebanon that we take patients who are suffering. So if you are a person who is very sick, having lots of symptoms, experiencing pain or shortness of breath or whatever, hospice is a building and a facility like we have here in Mount Lebanon, we have in Lawrenceville at the Canterbury Center. They're places where we can bring you in and take care of you with highly skilled doctors and nurses and aides and social workers, etc. The whole team, and it's a very patient-centered team that focuses on managing your illness and your symptoms. So that's one thing that hospice is to people. The other thing that most people don't realize is that most of what we do is in communities and in facilities. Most of the patients that I'm responsible for as a hospice medical director are actually living at home, and they are being taken care of by our team. And the same team that I talked about in the inpatient center with the nurses and the aides and the social workers and the doctors, we all go to the home. Particularly the nurses and the aides. They're the front lines of hospice care. They're the people that are helping take care of patients in the homes. Doctors oversee all of this, and we go out to see patients when they need us to go see them. But the real frontline care in hospice is the nurses. It really is a nursing-focused field. And the people who do it are, I always used to joke that they're doing God's work, and that was before I became one of them, and I still think that's true. Basically taking care of people at the most difficult times of their lives, and doing it in their homes and doing it happily and lovingly and in a wonderful way. So for most people that have experienced hospice, that's what they've experienced. They've experienced hospice in the home with the people coming to visit them and take care of them. So those are my 3 views of hospice. So hospice and palliative medicine are a medical specialty unto themselves. We have an affiliation with many educational institutions in the area, and we educate many resident physicians, medical students, nursing students, social workers, and so on. We bring them into our centers here in Lawrenceville and in Mount Lebanon. We take them out into the field with us. We have learners of various kinds who go make home visits with our staff. We have learners who come into the inpatient unit and experience that. We have a very highly regarded training program, especially for hospice and palliative medicine physicians, and they spend quite a lot of time with us here because it's such a great learning experience for them. Nowhere else do you get such a concentrated view of all the varieties of patients that come through hospice, and you learn so much, and the learners who've gone through and evaluated us tell us that, how much they've learned through this experience, so we're very proud of that. Hospice is the epitome of patient-centered care. I'll tell you a story about this. So about 10 or 15 years ago, I was doing a lot of work in patient safety and quality. And that's a very patient-centered, patient-focused activity for physicians. I mean, you really are focusing on the fact that there are patients and families that we want to protect and we want to provide the best quality of care. And one of my mentors was Dr. John Lloyd at Shadyside Hospital, but he was retired at this point. Anyway, we were talking about safety and quality work, and I had mentioned that I did end-of-life education, and he said, ah, he does end-of-life education too. It took me years to figure out what that meant, and what he meant was, he said, that is patient-centered care. End-of-life care is the ultimate in patient-centered care. It ties exactly with safety and quality. You are trying to do the most good for your patients, and you are trying to focus your care on their needs. And the question we most often ask in hospice when we have discussions about what we're going to do is, what's most important to you, the patient? Because that's really what this is all about. Our goal is your goal. If your goal is you want to make sure your wife gets taken care of after you're gone, that's our goal. If you want to have your grandchildren taken care of, or have something special, have a ceremony, a birthday, whatever it is, that's our goal. Coinciding with that is in order to make that stuff happen, we have to make sure you're comfortable. So oftentimes what we do in hospice is we very aggressively manage symptoms. We very aggressively manage pain and shortness of breath and nausea, because those are the things that keep you from your goals. We call it the hospice bounce, and what we sometimes find is we have patients who are extremely sick come on hospice, and we focus not on their illness, but on making them feel better. And once we start making them feel better, they suddenly have a little bit more energy to devote to that activity, whatever it is that they want to do. So, you know, our goal is not to give patients medications to put them to sleep or do anything untoward. Our goal is to make you feel better so that you can do the things you want to do. And that is the ultimate in patient-centered care, and that's what we try to deliver. So one of the reasons I'm in hospice now is because I was an intensive care doctor for 20-some years before I made this transition. I've only been doing hospice actually for a couple of years now, full-time only for just over a year. As an intensive care doctor, one of the things that brought me great distress and frustration was so many patients that I saw in the intensive care unit that we were doing so much to that was not comfortable. We were putting people on life support, we were putting lines and tubes and on all sorts of miserable things in them. And you know, that's great when you have a patient that you're going to save and bring back, and they're going to do fine and they're going to have a good life afterwards. But so often we're doing this to patients who clearly we all know how this story is going to end. And so we have patients that were clearly at the end of their lives, and we were getting in the way. We were disrupting the end of their lives, and we were doing more harm than good. And one of the things you find out when you've been doing that kind of thing for a long time is that most of that can be prevented with a simple conversation. And we used to, in the intensive care world and in medicine in general, try to get families to have that conversation. We used to say, well, you need a living will, but really what you needed was a conversation between the patient and the person who's going to be responsible for executing those decisions in the living will. So really, I don't need the living will. I need you to have a conversation with your son or daughter or spouse and say, you know what, when I get to this point, please just keep me comfortable. Because I can tell you that's what doctors do. You know, if you survey doctors and ask them, you know, when you have this diagnosis that's going to limit your life to 3 or 4 or 5 or 6 months, what do you want to do? Do you want more chemo? No, they don't want more chemo. They want to live their lives to their fullest, and they want to do the best they can with the time they have left. So what we want you to do is we want you to have that conversation and let your family know what you want. We need to know whether you value being alive in an intensive care unit or having chemotherapy for the last few weeks of your life and things like that. The short answer is most people don't. You know, most people want to live their lives on their terms. They want control. They want their dignity maintained. And the best way to do that is to have a conversation with your family. Some people have said that Thanksgiving's a great time to do this because you have everybody trapped around the Thanksgiving dinner table. But you have to do it sometime, because if you don't, then you're leaving them to have an agonizing decision in the intensive care unit. So I would often see families in the intensive care unit and they never had that talk. And I would say, well, what would he or she want at this point in their lives? And they'd say, I don't know, we never talked about it. She didn't want to talk about it, he didn't want to talk about it. You have to talk about it. And what we find is those are really rewarding conversations. because going back to what I said earlier, you find out what's important. And what's important to you is what's important to your family and to us, and that's what we want to focus on. I used to think I took care of the sickest patients, and that was true to some extent. I took care of the sickest patients in the hospital. Now I'm taking care of the sickest patients that aren't in the hospital. And a lot of the things that I did as an intensive care unit doctor, I'm now doing out in somebody's home or in our inpatient center and so on. And one of my focuses in the ICU was taking care of the patient, trying to get them better as best I could, but also making sure they were comfortable. So whatever journey they are on, I want them not to suffer as best I can. So the transition for me from ICU to this was very smooth and very seamless. I was focusing on the same things, and I think our staff focuses on the same things. I think that's why most of the people who are in this business are in this business, because they want to make people's transitions as positive as they can, as useful as they can, as focused on what they want as they can. So I think I'm still on the same page as I was before, just with a little different focus. I think, especially over the past couple years, I think we have started to really, really focus on not just trying to do the best care, but making sure we do the best care. And what I mean by that is that we have gone from presuming that we're doing okay to actually measuring everything. So we now do so many things to follow up with our patients and their families to make sure they have the supplies they need. Do they have the medicines they need? Did their pain get under control right away or as quickly as possible? Or are they no longer short of breath? So I think the thing that we're doing probably more aggressively than perhaps anyone in the country and certainly in the region is we're making sure that we are doing excellent care, documenting that we're taking excellent care, and improving where we're failing. So if there are areas where we're finding we're falling down, we are on top of it. And we make changes constantly trying to improve our care. So I think that that's probably the main thing that separates us. Well, as I said, I was an intensive care doctor, and I was an intensive care doctor actually down the street from the Mount Lebanon Center here at St. Clair Hospital. And so I got to work with family hospice a little bit, but I also got to work with, through work, I've been doing end-of-life advocacy for 15 years, teaching end-of-life courses and so on. So I really actually got to know the people on the other side of the fence in hospice and palliative medicine over the years, and I got to be good friends with a lot of them. And Dr. Bob Arnold, who's a leader in hospice and palliative medicine, gave me a call one day and said, would you be interested in this? And I was at a point in my career where I thought, yeah, I actually really am interested in this. So I started working part-time here and then full-time, and now I'm Chief Medical Officer here, and very happy that I made the transition.
Excellent. Excellent. Okay. I think we can turn you loose.
All right. That was
you
easy.
Did great. Yeah,
oh, good.